Hello everyone. Welcome to another edition of PEN or Pandemic Eye News. This is Dr. J coming to you from 486 Optometry, and you're watching this because either you've been forced to or you are extremely nerdy. But either way, welcome. So the topic today is uveitis, and this is actually one of my favorite diagnoses of the eye because weather conditioning causes a beautiful constellation of stars in the eye. None. Let's start. What is uveitis? So uveitis is the inflammation of the uvea, which is comprised of the iris, ciliary body, and the choroid. It can affect other parts of the eye as well, of course, but this is the area of the eye that is most affected. It may originate from within the eye or from an inflammatory systemic disease somewhere else. And it can happen at any age, but primarily between the ages of 20 and 60. What causes uveitis? Autoimmune diseases, as you guys know, which we'll go over in detail. Infections or tumors within the eye or other parts of the body. Injury, whether due to external injury or from surgery. And external toxins as well. What diseases are associated with uveitis? Here's a very long list of diseases that are well known to be associated with uveitis. We'll go over some more in detail later, but the ones that are most common are the ankylosing spondylitis diseases, the herpes diseases, MS, syphilis, sarcoid, toxo, and TB. So many things that can be associated with uveitis. So there are three different types of uveitis: anterior, intermediate, and posterior. Anterior being affecting the front structures of the uvea. They're the most common ones and are often idiopathic. Intermediate ones affect the vitreous usually, and sarcoid and multiple sclerosis are the most common diseases to cause intermediate uveitis, and the posterior, which affects the retina and the choroid. Now, what are the symptoms and signs of uveitis? Well, let's start with anterior. Symptoms of anterior uveitis include pain, redness, photophobia, tearing, and decreased vision. During slit lamp, you'll see the characteristic signs of the cells in flare, ciliary flush, chromatic precipitates. That's kind of how you know if it's granulomatous or non. Less common, you actually can see a low or an elevated intraocular pressure, hypopyon, iris nodules and atrophy, band keratopathy, and CME. And depending on what autoimmune disease is causing the iritis, these would be the differentials you would look at. For intermediate uveitis, symptoms include painless floaters, decreased VA as well. This has minimal photophobia inflammation compared to the anterior, and this happens more around the 15 to 40 years of age and is often bilateral. Now, the signs of intermediate uveitis include vitreous cells during slit lamp evaluation or dilated exam, white exudative material over the inferior or serrata, or well known as snowbank, and also cellular aggregates floating in the inferior vitreous, which is also called snowballs. Vitreous hemorrhage also can occur as well with this type of uveitis. Less common, peripheral retinal vascular sheathing, neovascularization, CME, even posterior subcapsular cataract, band keratopathy, secondary glaucoma, ERM, and retinal detachment. So a lot of things can show signs of uveitis. Now with posterior uveitis, not very fun. Symptoms are again blurred vision, floaters, but it definitely is even more rare to have pain and redness for this type of uveitis. Some signs of this include cells in the anterior and or posterior vitreous haze, retinal or choroidal inflammatory lesions, which is one of the very common signs of uveitis, and vasculitis. Now, these are some differentials of uveitis that you may want to consider that may present like uveitis but are not. One is you may think that you just have an anterior uveitis, but actually it's just a posterior uveitis that's spilled over to the front. So Make sure if you see anterior uveitis, you do check the vitreous and the retina. Make sure that's actually not coming from there. Traumatic iritis can cause symptoms that present like uveitis. Paget-Schlaffen, drug-induced red eye can look like uveitis sometimes. Glare, even contact lens use, can make the eyes be painful and photophobic, simulating uveitis. Tumors, and also endophthalmitis, possibly from injury or surgery. Now, what are the etiologies of uveitis? Now, this is, as you guys know, the very long list of things that can cause uveitis. And also the reason why I like uveitis so much is it's like a mystery, who did what and how did they do it. So it's a game we play to kind of figure out what type of uveitis it is, where is it coming from, and what can possibly cause it, test for it, and then hopefully resolve it and treat it. So with anterior uveitis, there's acute and chronic forms. With the acute, you can see here many different etiologies that can be causing uveitis, mainly being idiopathic. Probably about half are, we just don't know. The HLA-B27 are a very common class of the acute uveitis. Lens-induced, post-op iritis, Behçet's, Lyme's is all very common. For more chronic uveitis that just doesn't go away, juvenile idiopathic arthritis, which happens more in young girls and it's bilateral, is a common cause. Herpes simplex zoster, syphilis, TB, and very uncommon leprosy or brucellosis. With intermediate uveitis, this is actually mostly idiopathic, over 70%. We really don't know what causes it. Other things that can cause it: sarcoid, MS, Lyme, syphilis, toxo, and more unlikely, irritable bowel syndrome, Whipple, Sjögren's, and lymphoma. Now with posterior uveitis, as you can see this long list, there's many things that can cause it. With panuveitis, where it affects literally the entire eye, sarcoid, syphilis, VKH, Behçet's, and TB all can manifest itself throughout the whole eye. After surgery or trauma, endophthalmitis, of course, is a big thing to look for. If it affects the choroid, APMPPE, as you can read here, can be one. Birdshot, multifocal choroiditis, toxo, and presumed ocular histoplasmosis can also cause it as well. With retinitis, when it affects the retina, there's CMV, toxo, and acute retinal necrosis. And also some infections can cause posterior uveitis as well, as you can see with cat scratch and Lyme. So what are the workups for uveitis? The main thing for sure is your history and your review of systems. Many times just from talking with the patient and taking a really good history, you can already have an idea of what's causing their uveitis and really limit the need for unnecessary testing and prodding and poking for the patient, which would be great for everyone. Definitely with the history, ask if they've been anywhere that may have a higher chance of, let's say, Lyme or ticks. If they've been in certain states or been around certain animals, you can already rule out toxo or other types of diseases. Review of systems, if they've had surgery, if they've had injury, if they had certain types of diseases already present, that can lead you in the right direction. So definitely spend extra time talking with the patient if there's any suspect of uveitis. Do your whole exam, check those anterior chambers very well, turn off all your lights. That's a crucial thing. For me, that helps a lot. You can catch even a trace cell or flare with the lights off. With the lights on, it's harder to catch those little cells. Gonio, make sure you do that. Check for synechia. Dilate the patient. So you can look for intermediate and posterior uveitis. Check that vitreous for cells, that retina for snowbanks or snowballs. Again, even if you only see an anterior uveitis, you want to check for intermediate and posterior. And then, of course, the whole gamut of the labs, as you can read on this chart, all the typical ones to rule out many types of uveitis. For intermediate uveitis, you would do exactly the same thing as the anterior. Some additional tests you may order is fluorescein or OCT to see if it's affecting the vitreous. Lab testing for Lyme, toxo, cat scratch, and even cancer. Any of these things can cause intermediate uveitis, and MRI for multiple sclerosis as well. For posterior, pretty similar to intermediate. Maybe the only difference is urine tests for cytomegalovirus, and I read that even some ophthalmologists do a diagnostic vitrectomy to see if something is going on in the vitreous. So other things you can think of to refer out if you think it's posterior. Now, what are the treatments for uveitis? Well, for your typical anterior uveitis, you can prescribe that cycloplegic to give them some comfort and reduce that pain. Topical steroid, depending on how severe it is, go from Q1H to Q6H, and of course make sure you taper that steroid. Over a course, let's say 3 to 4 weeks, reducing a drop every week. You can do your own strategy, but make sure you do taper that steroid so you don't get a rebound. And of course, anything you're scared of or it's not improving, refer immediately. For intermediate and posterior uveitis, ophthalmologists can do subtenon steroid injections if the topical isn't working. If that doesn't work, they can even add systemic steroids and kind of hit it from the inside. And all else fails, they can even do cryotherapy or a pars plana vitrectomy. Now I like to end every lecture with statistics because it's fun. Whoa, I moved to the middle. Cool. So here are some statistics that I like to talk about real quick before we part ways. One is that it accounts for 10 to 50% of blindness in the US, which is quite a bit. The average presentation is about 40 years old when people get it. The incidence of uveitis is about 15 cases per 100,000 patients a year, so it's not too common. But if you do see it, those patients can go blind pretty quickly, so make sure you get on top of it. The anterior is most common, then the posterior, then the intermediate, which was, I thought, interesting. I thought posterior would be the most rare, but it seems to be a little bit more common than the intermediate. Chronic is more common than acute and recurrent, so definitely look for those conditions that during your case history that may cause chronic uveitis, and check the eye very closely for cells. Anterior and posterior uveitis have equal distribution of unilateral and bilateral cases, so no matter what uveitis you find, make sure you check the other eye. Even if the person only has symptoms in one eye, always check carefully the other eye because it may present there just less. About half are idiopathic, which is pretty amazing, where even with all these tests that we have, half the time we really don't know what causes it. So I thought that was interesting. And the last one is most common causes of certain uveitis. With the anterior, most common is idiopathic, then the HLA B27 class, then the juvenile arthritis cases. For the intermediate uveitis, the most common causes are again idiopathic, vast majority, sarcoid, and then MS. And then with the posterior uveitis, it would be toxo, then idiopathic, then CMV. Here are my references. Thanks for listening, and stay safe, stay healthy, and be there or be wrongus.